Dear ladies and gentlemen, Chairman, thank you for giving this opportunity to present a quite rare case of intrahepatic cholangiocarcinoma, and to bring our peers to communicate with the surgeons. Just background about cholangiocarcinoma intrahepatically. The second most frequent primary liver tumor. And in the West world, it's the frequency is 7 to 10 cases per 100,000 population. There is growing incidence and overall mortality, unfortunately. Surgery is remaining the most effective treatment. And for those who underwent surgery with R0 resection, we can achieve the overall survival till 20 to 60%, which is quite impressive. Less than 30%, unfortunately, of the patient, less than 30% of the patient eligible for this surgery in presentation. There is no evidence for neoadjuvant chemotherapy play the important role for those patients. And postoperative chemotherapy shows improving survival for those with positive lymph nodes and R0 resections. My case is a lady in 69 years old in presentation on 2014 with a large tumor with a right liver lobe invited, a right portal vein, and extending to the segment 4. No evidence of metastatic disease or nodal involvement. Adenocarcinoma found in the unknown origin, found primary in the biopsy. Negative upper and low endoscopy, no jaundice, no significant comorbidities, and BMI 26. Future liver remnant less than 20% of total functional liver volume. And we proposed a stage hepatectomy with Da Vinci robotic system assistance. I have to say that it was my 4th case of robotic ALPPS. It's based on the robotic surgery experience, more than 80 cases with incidence of malignancy in the cases more than 60%, and all types of surgery done by, like in open surgery, and the relation of major liver resections approximately 40%. The principle of ALPPS, it's the first step, the diseased liver deportalization and liver partition, and the only specimen removed during the first step is cholecystectomy. The second step is completion, right extended hepatectomy of diseased liver. This is a scheme of the first step, and this is a scheme of the second one. We get hypertrophied liver remnant, and we have complete removal of the diseased one. This is a CT scan of our patient in presentation with a big tumor involving right portal vein, extended to the segment 4. We used SI robotic system, Da Vinci system, and this is the surgery. Took quite a long time, approximately 8 hours, but without any accident during the surgery, without needs to make any blood transfusion. And typically we do mobilization, partial mobilization of the liver, and try to use the anterior approach, of course, but partial mobilization includes the exposure of the suprahepatic IVC with the main hepatic veins. Further, we go into the hilus and prepare for Pringle maneuver. We always prepare Pringle maneuver mainly not to use it, but just if we have some accident bleeding during the liver transection. We never use this in practice, but it's a very useful tool to improve a vision to the IVC, to anterior wall of IVC. Once it's done, we actually do the incomplete cholecystectomy, and we leave the gallbladder connected to its bed in order to facilitate the movement and exposure during liver transection. The first part is hepatocaval dissection. This is the most important but also difficult because of difficulties of exposure part of the operation. But the view is amazing, and really three-dimensional vision improving quality of life of the surgeon during this part. And we easily can see the short hepatic veins, and we can control them either by suturing, either by clipping and transecting using scissors or any energy device. It depends on the personal preferences. Now we're going up until it's possible, but sometimes it is not possible, especially for the fatty patient, to go too high away until you get main hepatic veins. So sometimes you leave it until the end of the operation and finish a transection of the caudate lobe after you finish the parenchymal transection, which may facilitate actually the vision of the anterior wall of IVC. And this is a small tip I learned from the more than 30 major liver resections. This completion of mobilization of the right lobe without actually turning off the IVC, which makes the patient very stable during this part of surgery. We go again to the liver hilus. You see dissect the right portal vein and right hepatic artery, leaving the right hepatic artery untouched. Very important not to traumatize, because in the first part of the operation, this is the only blood supply for the diseased liver. The reason we leave diseased liver on the spot is prevent postoperative liver failure after we complete the first part of surgery. So arterial blood supply extremely important. At this step, I don't cut a right portal vein in order to prevent trauma on the right hepatic artery, because in one of the cases of open surgery with ALPPS, I experienced a very unfortunate trauma of the right hepatic artery when the very heavy right hepatic lobe fell down into subdiaphragmatic space. And since then, I only closed the flow to the right portal vein without cutting in really. And I cut it in the second step of the ALPPS. Divided completely on the second step of the ALPPS. Now we start the transection. The transection is actually done exactly between this left lateral septum. We're using energy device, and this is something that you know from laparoscopic surgery maybe, because this is a water jet by Erber. And the water jet directed by, manipulated actually by the assistant, and this is a kind of restriction. We can use it instead of CUSA. And it is very, very good for the normal liver, but in my experience, not very good for cirrhotic liver. It's not works very well in cirrhotic liver. Actually, nothing works well in cirrhotic liver. So this, step by step, we cut the liver on the two pieces, and the diseased liver finally being with arterial blood supply only, whereas the remnant liver have the normal blood supply and the drainage. No one of bile ducts not divided during the first step. Because of shortness of time, I just want to go forward. So this is the view of the two different liver and the gallbladder removed from in the first step. This is the completion of the second step after 14 days, once we have the hypertrophied future remnant liver. This is dissection, complete dissection and division of the right hepatic vein and right extended hepatectomy done. This specimen and the pathology report was more differentiated adenocarcinoma, 6 centimeter pleomorphic type of intrahepatic cholangiocarcinoma. The same lady, 1.5 years later on, been found on MRI with a single recurrent metastasis in the upper pole of caudate lobe. And we proposed the redo surgery because, oh, sorry. This here image, and we've been very much surprised by what we found during the surgery. We used XI this time, and we planned either anatomical caudate lobectomy or partial caudate lobectomy if we found easily the metastasis. You see, there is no adhesions after the first surgery. This was quite surprising. And after some very short work, we found the metastasis on the upper lobe. I did partial resection with good margins. Pathology reports the same. And unfortunately, less than 1 year later on, we found another one. This time, the patient refused the surgery, even though it was quite the quick recovery after both. And this time, we treated by SRBT. In May 18 this year, there is no recurrence in the liver. After she'd been diagnosed with a single metastasis in the low lobe of the right lung and underwent robotic low lobectomy of the lung on the right type. She is currently healthy, and unfortunately last month diagnosed with left breast invasive duct carcinoma without evidence of any metastatic disease. So what makes this case so special? 4 years survival so far in this case of intrahepatic cholangiocarcinoma. Metastatic disease was treated by surgical methods mainly, and no chemotherapy added during the whole period of time. 2 liver resections, ALPPS and caudate lobe resection, and lung lobectomy. All surgeries performed with Da Vinci assistance. And SBRT had a stable, good response and replaced 1 more liver surgery for metastasis with difficult location, close to single, actually, left hepatic vein. Recovery was nice after every surgery. Do I have any time? 2 minutes. So there are some anecdotic case report similar with our treated by some unusual methods. One of them in Japanese, so I couldn't complete the reading this time. But I wanted to say something. The main reviews, well known to all our audience and also to our friend here. And the main things that expert consensus statement done recently, and the main points was that no place for adjuvant therapy for the patient treated by R0 resection and without lymph node invasion. And the surgical treatment is defined by ability to completely remove the disease with curative intent while leaving an adequate remnant. Extrahepatic disease, multiple bilobar or multicentric tumor, and lymph node metastasis beyond the primal echelon, formal contraindication for resection. Regional lymphadenectomy should be considered as a standard part of the surgery, and the patient with high-risk features, the routine use of diagnostic laparoscopy with selective use of laparoscopic ultrasonography is recommended. So I want to complete, just because of shortness of time, there's some very aggressive primary liver tumors may have good character. Robotics may play a role of preferable surgical approach for performing massive liver resections, even for such big as ALPPS. Robotics may be very beneficial for parenchyma sparing redo liver surgeries, in combination of different modalities and selective non-chemotherapy treatment may play a role in liver recovery, saving quality of parenchyma. Cooperative team of surgeons, medical oncologists, radiotherapy oncologists may bring favorable results for carefully selected patients with potentially dismal tumor. Thank you for your attention.